My student, I will discuss for you glaucoma in 2 lectures. This is the first one, and the objectives for this lecture are clinical anatomy of the anterior segment of the eyeball. And I mean by anterior segment is the cornea, anterior chamber, iris, posterior chamber, and the lens. Aqueous humor secretion and drainage, because the most important factor in building the intraocular pressure. Then the intraocular pressure, which is the most important factor in glaucoma. The intraocular pressure distribution in general population, how much frequent ocular hypertension is present in general population. Then definition for glaucoma, classification of glaucoma, and we start with the most important type of glaucoma, most frequent type of glaucoma, which is primary open angle glaucoma. By this diagram, I will show you the anatomy of the anterior segment of the eyeball. This is the cornea, and the posterior continuation of the cornea is the sclera. This area, which is the transitional area between the cornea and sclera, is called the limbus. This area is opposite to the area of trabecular meshwork, the site for drainage of aqueous humor. This triangular muscular tissue is called the ciliary body. The ciliary body is composed of 2 parts. The anterior 1/3 is called pars plicata. And here in this lecture, this is our interest, because from this part of the ciliary body, the aqueous humor is secreted. The posterior 4 mm of the ciliary body is called pars plana. From the anterior surface of ciliary body, the origin of diaphragm-like structure, which is called the iris tissue. The iris tissue is perforated centrally. Here there is a aperture, which is called the pupil. The mushroom-like shape anterior to the iris, this area is called the anterior chamber, while the slit-like space, this slit-like space between the iris and the lens posteriorly is called the posterior chamber. The lens is suspended in its position centrally inside the eyeball by these fibril-like structures, which are called the zonules or suspensory ligament to the ciliary body by its ciliary processes. This diagram showing us the magnification of the angle of the anterior chamber. So you can see here, this is the limbus, here the cornea, and from this side is the sclera, and you can see the Schlemm's canal embedded in the limbus. Corresponding to the Schlemm canal is the trabecular meshwork. This is a sieve-like structure. This is the ciliary body here, and emerging from the anterior surface of the ciliary body is the periphery of the iris tissue. So when the aqueous humor here in the angle of the anterior chamber transmitted through these orifices of trabecular meshwork to inside the Schlemm canal by the inner wall of Schlemm's canal by phagocytosis, and then by the outer wall of Schlemm canal by many collecting ducts into epicleral veins and then to the systemic circulation. This is the trabecular meshwork under high magnification. Pleased to see these multiple orifices and multiple layers of trabecular meshwork through which the aqueous humor transmitted from the angle of the anterior chamber to reach the inner wall of Schlemm's canal. 80 to 90% of the aqueous humor is secreted by non-pigmented epithelium of ciliary processes of pars plicata of the ciliary body into the posterior chamber by active mechanism. And we mean by active mechanism, it needs energy to push the fluid against its concentration from pars supplicata into the posterior chamber. And this process is activated by many enzymes, including sodium, potassium, ATPase enzyme. Still 10 to 20% of the aqueous is secreted into the posterior chamber by non-pigmented epithelium by ultrafiltration, which depend on the difference in blood pressure between intravascular and extravascular within the pars applicata, and also on the difference on oncotic pressure between the pars applicata and the posterior chamber. Then the aqueous is passed through the posterior chamber and then through the pupil into the anterior chamber and then to the angle of the anterior chamber. Also here 80% is passed through the trabecular meshwork into systemic circulation, and still 10 to 20% is passed through the anterior surface of the ciliary body, which is called uveoscleral pathway, non-conventional pathway, into the supraciliary space to be absorbed here by the blood vessels of ciliary body and blood vessels of sclera. There is a very negligible amount of the aqueous is transmitted through iris tissue into systemic circulation and the endothelium of the cornea into the corneal tissue. The normal intraocular pressure in general population is 10 to 21 millimeter mercury, and if the intraocular pressure is normal between 16 and 21 millimeter mercury, still there is risk of a glaucoma, or the prevalence of primary open-angle glaucoma is 1.5%. If there is rising of intraocular pressure between 22 and 30 millimeter mercury, the prevalence of primary open-angle glaucoma is 8%. And when there is more rising of intraocular pressure, 31 millimeter mercury, the prevalence of primary open-angle glaucoma is only 25%, not 100%. So we can say that the intraocular pressure is an important factor that play a role in pathogenesis of glaucoma, but it is not the only story in pathogenesis of glaucoma, and there are other factors that causing optic nerve damage, but they are not discovered yet. This is a Gaussian curve for normal distribution of intraocular pressure with right skew deviation. This is a right skew deviation. From this curve, you can see that 5% of general population, they have intraocular pressure more than 21, but they are normal. I mean normal, they have no any sign or symptoms of primary open-angle glaucoma, and our diagnosis for those people is not glaucoma. They are cases of ocular hypertension or glaucoma suspect, and we should not treat those people. This is the definition of glaucoma, and as you see, we should have 3 criteria for diagnosis of glaucoma. The most important one is to ensure that there is optic nerve damage. The second one is specific visual field defect, and lastly, but not mandatory, a rising of intraocular pressure. Any 2 of these 3 factors or criteria is enough for diagnosis of primary open-angle glaucoma. I mentioned before, there is no need to treat patients with ocular hypertension or glaucoma suspect. But if there is one of the following association, we should start treatment, and we should not wait till there is optic nerve damage and visual field defect. So if those people, if they have intraocular pressure 30 millimeter mercury or more, because the prevalence of primary open-angle glaucoma is 25%, and if there is sign of optic nerve damage, cup disc ratio is 0.4 or more. If there is a family history of a primary open-angle glaucoma, and if there is sign and symptoms of pathological myopia or high myopia, so we should start a treatment in spite of having only one factor, which is rising of intraocular pressure without visual field defect, without optic nerve damage, because the risk of glaucoma or the prevalence of glaucoma is high. Glaucoma can be congenital, which is presented just after birth up to 16 years of life, and we have only one type of this glaucoma, which is usually angle closure glaucoma, because there is dysgenesis of the angle of the anterior chamber, or can be acquired glaucoma, and the most time for presentation of this type of glaucoma is usually after age of 40. For this reason, we should check the intraocular pressure for any patients visiting our department after age of 40, and it can be open angle or angle closure glaucoma, and each one of them can be primary. It means just glaucoma without any intraocular disease, or might be associated with intraocular disease, so it is called secondary glaucoma. By this contact gonio lens directly on the eye of the patient, and through this mirror, we can visualize the angle to differentiate glaucoma into open angle and angle closure glaucoma, because most cases of angle closure glaucoma, the treatment is surgical treatment, while if the angle is open, so we can start medical treatment, and if there is no control for intraocular pressure in spite of using maximum medical treatment, then surgery is indicated. For this reason, gonioscopy is an important examination for patients with glaucoma. This is a Goldman gonioscopic lens, and this is a contact lens toward the eye of the patient, and the ophthalmologist or the viewer or the examiner usually looking through this reflecting mirror to see the angle of the anterior chamber, like in this mirror. So the reflected light is coming from the anterior chamber, from the angle of the anterior chamber, then reflected by this mirror toward the eye of the viewer or examiner to visualize the angle or the structures of the angle of the anterior chamber. This is exactly what can the viewer or the examiner see by using a slit lamp with contact lens, gonio lens, to visualize the periphery of the iris. This is the periphery of the iris. This is the periphery of the cornea. And here the details of the anterior chamber is located. So, for example, this reflecting mirror is placed at 12 o'clock superiorly. So we can visualize the angle inferiorly at 6 o'clock. And then we rotate this reflecting mirror around the eye to see all the details of the angle, or 360 degree of the angle of the anterior chamber, to differentiate the open angle from angle closure. This is exactly show us what the viewer can see by gonioscopy. For example, here in this patient, the angle is wide, and the examiner can see the periphery of the iris, the anterior surface of the ciliary body, the scleral spur, the trabecular meshwork. This is the trabecular meshwork. And to the periphery is the Schwalbe line, which is the termination of the cement membrane of the cornea. We have here another patient, and this patient having slightly narrow angle, but still we can see the trabecular meshwork and the Schwalbe line, but there is no view for the anterior surface of the ciliary body or scleral spur. So in spite of narrow angle, but still the angle is open because the aqueous is can pass through the trabecular meshwork. This is the trabecular meshwork into the systemic circulation. In this patient, the examiner can see only the Schwalb line. There is no details for the anterior surface of ciliary body or scleral spur of trabecular meshwork. So here the angle is closed. And even in this patient, you can see no any details of this structure. For this reason, those two patients, for example, having angle closure glaucoma, while those 2 or 3 patients here, they have open angle glaucoma. This is a subjective method for assessment of the angle of the anterior chamber, and I mean by subjective that the examiner or the viewer or the ophthalmologist using his evaluation to assess the angle of the anterior chamber. Nowadays, we can take an image to the anterior chamber by OCT, ocular coherent tomography. But I am sorry, I forgot to bring a slide for the image of the anterior chamber by OCT. So please to search by Google and write the assessment of the angle of the anterior chamber by OCT. And you can see many images for this purpose. This is an objective way for assessment of the depth of the angle of the anterior chamber. Fundal examination to visualize the optic disc is mandatory for all patients with glaucoma. Normally, we should evaluate the optic disc and its relation to the central optic cup. So you can see here, there is an area with a color slightly less than the color of the periphery of the optic disc. Normal color of the optic disc is usually plethoric red, while this area looks pallor, and by stereoscopic view we can see a depressed area here in the center of the optic disc. This is present in all people, but the normal relationship of cup to the disc is usually less than 30% in normal person. Maybe 30, maybe 20, maybe 10%, or sometimes there is no cup. There is overcrowding of the axons of ganglion cells. Why this area is depressed normally? Because the number of axons of ganglion cells in this area is less than the distribution of ganglion cells at the periphery of the optic disc. And also it looks pallor because the blood supply here to the optic nerve head is less than other areas of the optic cup. So normally the vertical diameter of the cup from here to here, it should be less than 30% of vertical diameter of the optic disc as a whole. While in patients with glaucoma, usually the cup disc ratio is more than 30%. For example, in this optic disc, the vertical diameter of the cup comprise 40%, about 40% of the vertical diameter of the optic disc as a whole. And you can write CD ratio is 0.4. So this is a sign of a glaucoma. In this patient, the CD ratio may be 0.5 or 50%. This is again a subjective evaluation. It is the evaluation of an ophthalmologist. Here I will mention for you just my experience as an ophthalmologist. So it is subjective evaluation. For example, the CD ratio for this patient might be 0.5. For this patient might be 0.6. For this patient 0.7. For this patient 0.8. But this is just subjective evaluation, may be evaluated by different value by any other ophthalmologist. Put in your mind that 2% of general population, they have CD ratio more than 0.3, but they are normal. How we know? We should send those people for visual field assessment and IOP measurement. If IOP is normal, if there is no visual field defect, so he is one of the 2% of general population. They have CD ratio more than 0.3, but they are normal. As you see in the previous slide, there is variation in assessment of CD ratio subjectively. For this reason, there is need to assess the CD ratio by objective method. And here is the assessment of the CD ratio by Heidelberg retinal tomography. So you can see the red color here is the cup. The green color is normal peripheral optic disc tissue, and this blue color is the transitional area between cup and normal tissue. And here, if you increase the magnification, you can see exactly the CD ratio measured objectively. This test is used for diagnosis and also for follow-up if there is a progression of enlargement of the CD ratio with time. Again, there is introduction of the OCT, ocular coherent tomography, in assessment to the cup disc ratio. This is the cup and this is the whole disc from here to here. This is the cup and this is the whole, and then to measure the CD ratio objectively, and this is an example of normal CD ratio. Another example for assessment of CD ratio by using OCT, and you can see here, this is a large cup. You can see the depression or excavation of the optic cup inside the optic disc. This is the size of the optic disc, and this is the size of the optic cup. So this is an objective method to assess the CD ratio, and in this case the CD ratio is usually or is large than 0.3%, definitely for patients with a glaucoma if there is any other factor to support our diagnosis. The last subject in this lecture is to discuss the most important and most frequent type of glaucoma, which is primary open-angle glaucoma. The criteria for this type of glaucoma, usually the age of patient is above 40, and the most common age for the disease is above age of 60 or 65. The intraocular pressure is usually more than 21 millimeter mercury. By gonioscopy or OCT, the angle is open, so you can see all the details, including the trabecular meshwork. The CD ratio is more than 0.3. There is visual field defect. I will show you the criteria for visual field on the following slides. And nowadays, we should measure the corneal thickness because the intraocular pressure is usually measured through the cornea by compression on the cornea. So corneal thickness might affect our measurement. The normal corneal thickness is between 520 or 545 micrometer. Any cornea thicker than this figure might give us a falsely high intraocular pressure, and corneal thickness less than 520 might give us a falsely low intraocular pressure. For this reason, they add corneal thickness as an important factor in diagnosis of primary open-angle glaucoma. Two theories by which we can explain the pathogenesis of optic nerve damage and enlargement of CD ratio. The first one depends on the perfusion pressure to the retinal tissue and optic nerve head. This perfusion pressure is depend on the difference between blood pressure inside retinal blood vessels and intraocular pressure. So rising of intraocular pressure lead to decrease the perfusion pressure and ischemia to the sensory retina. The other theory mentioned that increase in intraocular pressure lead to stretching the ocular coats, I mean the sclera, and there is pressure by scleral canal directly on optic nerve fibers during its exit from the eyeball into the orbit. Risk factors and association for primary open-angle glaucoma include age after age of 65, because with advancing age there is sclerosis and deposition of glycosaminoglycans inside the trabecular meshwork lead to narrowing of the opening of the trabecular meshwork, which are called spaces of Fontana. Primary open-angle glaucoma is more common in Negroes and Asians, with a positive family history in first-degree relatives, and also the prevalence and incidence is more in myopic patients, especially pathological myopia. Patients with primary open-angle glaucoma, usually they have no symptoms, and most cases are discovered accidentally by measurement of intraocular pressure or visualization of the fundus or assessment of the visual field. Other symptoms include early presbyopia, I mean before age of 45, which is usually occur in normal person, and usually those people might change their glasses more fast than other people because of rapid development of hypermetropia. The most important point that those people, they don't complain ocular ache or headache, because the rising of intraocular pressure is usually in a gradual way. Signs of primary open-angle glaucoma include rising of IOP more than 21, fluctuation of intraocular pressure. Normally there is a fluctuation in normal person, but this fluctuation should be not more than 5 millimeter mercury between, for example, morning and evening. Also, you can see enlargement of CD ratio by fundal photograph, by Heidelberg retinal tomography, and also by OCT. And also, if you send those people for visual field assessment, usually there is a typical visual field defect, but the visual acuity is usually normal till the advancing of the disease and there is severe optic nerve damage, definitely by gonioscopy, whether by objective or subjective examination, the angle is open. This is the central 30 degree of visual field of your left eye, because normally the optic disc is located nasally and projected field to the temporal side. So this is the projection of the optic disc. Here you can see there is an absolute scotoma, which is called the blind spot, and there is extension of superior arcuate scotoma, because the blood vessels here in the retina are more vulnerable for ischemia. For this reason, this is the first area of retinal tissue affected by a glaucoma. You can see here the visual field is normal centrally for the macula, and this is explain normal visual acuity for those people in spite of arcuate scotoma. If the patient in previous slide is left without treatment or under treatment, so there is more destruction to the retinal tissue and there is more enlargement of arcuate scotoma, to involve hemi of the central retina, and also quantitatively you can see there is conversion of relative scotoma into absolute scotoma. This is absolute scotoma. If the same patient is not treated properly, this leads to more ischemia of the retina and development of inferior arcuate scotoma. And still, the macular area is intact. For this reason, in spite of this large absolute scotoma, still the visual acuity is normal till there is involvement of this area, then the patient becomes blind if we continue without proper management. If we treat our patient with a primary open-angle glaucoma, whether by medical or surgical treatment, how we know that our patient is safe and there is no progression? This is usually done by series of visual field and series of HRT, Heidelberg retinal tomography. For example, these images done and 6 months between one and the other, and the software of this machine will give us a clue that there is progression or not. It means we are reaching a safe or target intraocular pressure or not. Our aim in management of patient with a primary open-angle glaucoma is to preserve what remains from the optic nerve. It is impossible to regenerate the optic nerve damage. And firstly, we start with medical treatment, and the first choice is prostaglandin agonist, including many drops like latanoprost, bimatoprost, tafloprost, many types of drops. These drops are expensive, while the last choice is parasympathomimetic drugs, for example, pilocarpine. The prostaglandin agonist is acting by increase the drainage of aqueous through the uveoscleral pathway, while parasympathomimetic drug pilocarpine acting by increased drainage of aqueous through the trabecular meshwork, because these drops lead to contraction of longitudinal muscle of the ciliary body, which are attaching to the scleral spur. So contraction of muscle lead to stretching the spaces of trabecular meshwork and more drainage of aqueous humor through the trabecular meshwork. Why prostaglandin agonist is the first and pilocarpine is the last? Because prostaglandin agonist is usually given once per day, while parasympathomimetic drug is usually given 4 times per day. Second, continuous contraction of ciliary muscles lead to induce accommodation and artificial myopia, and also continuous use can lead to meiosis, permanent meiosis of the pupil, making future intraocular surgery difficult, especially, for example, for cataract surgery, and also can induce chronic conjunctivitis, occlusion of the puncti of drainage of tear. Other drugs include beta blockers. It is an old and cheap drug. It acting by decreased aqueous production. Dorzolamide, it inhibits enzyme sodium potassium ATPase and decrease aqueous production. Brimonidine is an alpha agonist acting by decrease the aqueous production and increase drainage of aqueous. Usually we start with one medication. If we cannot reach the target pressure or safe pressure, we can use, and the maximum uses we should use 3 drops of these topical drops. Surgical treatment of primary open-angle glaucoma is indicated only for the following reasons. First, if we cannot reach the target pressure or serve intraocular pressure with maximum medical treatment, which is 3 drops, expensive drops, allergy to these drops, the drops are not available, and if the patient is not compliant with the using of these drops. We have generally three types of surgery or methods, which are laser trabeculoplasty, cyclodestructive procedure, and trabeculectomy. Laser trabeculoplasty is usually done by using slit lamp and gonio lens to visualize the angle of the anterior chamber and visualize the trabecular meshwork, and then firing the laser directly to the trabecular meshwork in separated, not confluent, not one beside the other. So this creates a photothermal effect and induce scar in these areas. Scar in these areas, stretching the tissue in between, lead to enlargement of spaces of trabecular meshwork and more drainage of aqueous humor and lowering the intraocular pressure. The other method for surgical treatment of primary open-angle glaucoma is cyclodestructive procedure. Cyclo means ciliary body. Destructive is the destruction of ciliary body. This can be done by laser, for example, diode laser, or freezing of the anterior part, the first 2 millimeters of ciliary body, which is pars supplicata, the site for secretion of aqueous humor. So just we calculate 2 millimeters from the limbus here in this area, and we can apply our laser or freezing through the conjunctiva and then sclera and then pars supplicata to distract the ciliary processes, the site for secretion of aqueous, and by this method we can decrease the secretion of aqueous and lowering the intraocular pressure. The third surgical method for treatment of primary open-angle glaucoma is trabeculectomy with or without anti-metabolites. First of all, we open the conjunctiva from the limbus. So this is retracted conjunctiva from the limbus, and there is exposure of sclera like here. Then we open rectangular flap, partial thickness, like in this. So you can see this is a partial thickness. Still here, there is sclera embed, because full thickness, it lead to open the sclera and exposure of ciliary body. So this is a partial thickness, and this is the flap. Then we cut part of trabecular meshwork, because this area is corresponding to the trabecular meshwork, like in this area. So there is exposure of the periphery of the iris. This periphery of the iris acts as a policeman to occlude this opening. For this reason, we pull the iris, the periphery of the iris, and we cut it. This is called peripheral iridectomy. And then we replace this flap into its normal position, but we should not suture it firmly, because it ends with occlusion of the fistula. It usually it's sutured by loose stitches to create a fistula between the anterior chamber and the subconjunctival space, as I will show you in the next slide. So after trabeculectomy, you can see that the aqueous is secreted from ciliary processes of pars supplicata, passed to the posterior chamber, and then through the peripheral iridectomy and through the trabeculectomy, because here we cut full thickness of sclera, the aqueous pass, and because there is loose stitches here between the flap and sclera, so the aqueous is passed beneath the conjunctiva and then absorbed by conjunctival blood vessels and episcleral blood vessels into the systemic circulation. Because this is a fistula, so sometimes we use anti-metabolite to avoid occlusion of this fistula by using mitomycin C or 5-fluorouracil. At the end of trabeculectomy, And before we suture the conjunctiva, you can see this is the scleral flap, which is sutured only by 2 loose stitches to give a chance for leakage of aqueous from the anterior chamber through this wound to be accumulated here. Then this area is covered by conjunctiva. If you examine this patient weeks or months later, you can see there is elevation of conjunctiva at this area superiorly, and this is peripheral iridectomy. This is the cornea, this is the pupil, and there is accumulation of aqueous humor beneath the conjunctival tissue. This is a sign of successful trabeculectomy. To increase the success rate of trabeculectomy and to avoid occlusion of this fistula, sometimes we insert other device in addition to the trabeculectomy. For example, this is a multi-node tube. So it is usual trabeculectomy, and we insert this tube beneath the conjunctiva. So the aqueous is passing from the anterior chamber through this tube to be leaked in subconjunctival tissue. Another device to increase the success rate and to prevent occlusion of trabeculectomy is Ahmed valve. This is the valve, Ahmed valve, and this tube is inserted into the anterior chamber, and this valve is sutured to the sclera beneath the conjunctival tissue. This photo of the eye of the same patient with who underwent trabeculectomy and insertion of Ahmed valve, and you can see the end of the tube in the anterior chamber. This is the cornea, and behind the cornea in the anterior chamber you can see this is the end of the tube, and the aqueous pass through from the anterior chamber through this tube into the valve, which is inserted beneath the conjunctival tissue on the temporal side. This is another device which is called express valve. This young patient underwent trabeculectomy with insertion of express valve because the intraocular pressure is 38 millimeter mercury with maximum medical treatment, and this is the indication for surgery for this patient. This is the intraocular pressure on the first post-operative day for the same patient with a trabeculectomy and express valve. So you can see there is drop of intraocular pressure from 38 with maximum medical treatment into 8 millimeter mercury without any medication. So this is the end of first lecture, and I hope to see you again in the second lecture for glaucoma. Thank you very much.